Hi everyone, this is Sumati Christopher from Triple M College of Nursing. Today we are going to discuss about MAS. MAS is Meconium Aspiration Syndrome. In this class, with the following subtopics we are going to discuss. They are Introduction, Definition, Red Flags, Incidence and Prevalence, Classification, Risk Factors, Pathophysiology, Clinical Manifestations, Diagnosis, Management, Potential Complications, and the prevention of MAS. Meconium aspiration in newborn occurs when the first stool in the fetal GI tract passes into amniotic fluid before delivery, and it aspirates into newborn's airway with the first breath. Meconium aspiration syndrome describes the distress the newborn experiences following meconium aspiration, including respiratory distress and lung infection. Definition. According to the definition, meconium aspiration syndrome is defined as respiratory distress in newborn infants born through meconium-stained amniotic fluid. Red flags in MAS is mainly to give caution for us to prevent complication. The complications predicted are lung problems, neurological damage, and even death. The severity of impact on respiratory system depends on the viscosity of meconium and the degree of hypoxia from aspiration. Usually, for all the newborn with normal delivery, endotracheal suctioning is not recommended. In case of MAS, we have to go for non-vigorous endotracheal suctioning. The incidence and prevalence of MAS, MSAF, that is meconium stained amniotic fluid, occurs in 10 to 20% of all newborns. Out of it, 5% develop with respiratory problems, and mostly it occurs in term infants comparing with premature infants. And this MAS is more common in, that is about 52% more prevalent in post-term infants, that is more than 42 weeks of gestation. Up to 10% of newborns develop with respiratory distress due to aspirations, and 33% of infants with meconium aspiration require mechanical ventilation during the treatment. Now we'll see the classification of MAS. It is classified like mild, moderate, and severe. In mild, less than 40% supplemental oxygen is required for less than 48 hours. In moderate MAS, greater than 40% supplemental oxygen is required for 48 hours or longer period. Then the severe is the intubation and mechanical ventilation are required for longer than 48 hours. See the risk factors of MAS. It is divided into neonatal risk factors and maternal risk factors. According to the neonatal risk factors, post-term gestation, that is more than 42 weeks of gestation, thick meconium staining of amniotic fluid, fetal stress and hypoxia in utero, small for gestational age, and low Apgar scores. Maternal risk factors are presence of chorioamnionitis, uh, drug usage, tobacco usage, chronic illness such as diabetes, cardiovascular disease, and hypertension. Now we are going to discuss the pathophysiology of MAS. Due to hypoxic stress to the fetus passes the meconium in utero. After the passage of meconium, it is ingested by the fetus and it travels to the lower airway. There the airway obstruction occurs. So just because of the obstruction and inactivation of surfactant, atelectasis happens. So there is a trap of meconium in the respiratory tract. So just because of the obstruction, just because of the small airway diameter, the hair hunger occurs. Because of the hair hunger, the newborn tries to inhale more air, so more meconium aspirate into the tract, which will cause hyperinflation, acidemia, and hypoxemia. Now we are going to see the clinical manifestation of MAS. Presence of meconium staining on the vernix, umbilical cord, and nails of the newborn. Tachypnea and hypoxia will be present. Depressed at birth. Nasal flaring will be. Rales and rhonchi will be present. Expiratory grunting, nasal flaring, and retractions sometimes it will be present. And classic barrel chest due to hyperinflation will be present. Hypothermia, hypoglycemia, and hypocalcemia may occur. Low APGAR score, mostly it is less than 7. It may progress to respiratory cyanosis, pallor, gasping, ineffective ventilation, and hypotonia. Diagnosis. Diagnosis will be made with the evidence of MSAF, that is meconium stained amniotic fluid, visualization of meconium via laryngoscopy in respiratory passages and vocal cord. Chest X-ray show uneven distribution of patchy infiltrates, air trapping, hyperexpansion, and atelectasis. Poor oxygenation, pulse oximetry will show, and ABG analysis report also will denote the MAS. The general approach in the management of MAS: maintenance of adequate oxygenation and ventilation, maintenance of adequate blood pressure and perfusion, correction of any metabolic abnormality including hypoglycemia and acidosis, which can increase oxygen consumption. Empirical antibiotic therapy can be started, and care in neurothermal environment, and minimal handling of the infant to avoid agitation. During the suction, initially we have to just do the oral suction, then we have to go for nasal suctioning, and after the baby is born, then we can go for endotracheal suctioning. So this is all the ways to manage, and if the measures are not able to manage MAS, then we can go for ECMO therapy. The potential complications associated with meconium aspiration syndrome are airway obstruction, insufficient surfactant protection, long-term reactive airway disease, neonatal hypoxia, neurological damage due to prolonged decreased oxygenation, pneumonia, pulmonary hypertension, and respiratory distress. See the prevention. It includes controlling the risk factors during pregnancy, which include avoiding tobacco, illegal drugs, getting regular exercise and managing weight, following appropriate diet and medication if any chronic uncontrolled diseases, attending prenatal visits and following the orders without any fail, monitoring fetal heart rate during labor, having neonatal care available at delivery if meconium stained amniotic fluid is present. Thank you. See you in the next class.